Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 318 of our pharmacotherapy series, which majors in shock. The first question applies to patient NGT in part 317 of this pharmacotherapy series. After the transfusion, NGT has a serum potassium concentration of 4.7 milliequivalents per liter compared with 4.2 milliequivalents per liter before the transfusion. Could this be a result of the blood product? What other potential acute transfusion-related complications are associated with packed red blood cell administration? Possible risks of blood transfusions include febrile and allergic reactions, hemolytic reactions, electrolyte abnormalities, infectious disease transmission, coagulopathies, and immunosuppression. Febrile non-hemolytic and allergic transfusion reactions are the most common adverse reactions. Transfusions can also cause acute lung injury from activation of recipient neutrophils, which cause capillary endothelial damage. Transfusion-associated circulatory overload results in pulmonary edema in patients with limited cardiac reserve, e.g. elderly, infant, renal failure, heart failure, or after massive transfusions. Recognition of donor-recipient ABO incompatibility and the signs and symptoms of a transfusion reaction, e.g., anxiety, infusion site pain, chills, rigors, fever, hypotension, tachycardia, hemolysis, or hemoglobinuria can prevent unnecessary morbidity and mortality by stopping the infusion and providing supportive therapy. Hemolytic transfusion reactions are the most common cause of fatalities from blood transfusions. However, it is unlikely that NGT is having a true hemolytic reaction. Bank blood is stored with a citrate anticoagulant additive. With multiple transfusions, the large amount of citrate can cause hypercalcemia and acid-base abnormalities. Hyperkalemia also can occur because transfusion of stored blood causes the release of potassium from hemolyzed, ruptured, red blood cells. The increase in serum potassium observed in NGT may be from the blood product, although, the average amount of extracellular potassium ranges from less than 0.5 to 7 milliequivalents per unit of blood, so the transfusion is unlikely the culprit. The increased potassium may simply reflect hemolysis of blood cells in the test tube after the blood draw. In either case, the measured serum concentration of 4.7 milliequivalents per liter is not sufficiently high to warrant immediate treatment but should be monitored. Blood products and donors are screened for disease, thus, transmission of bacterial or viral illness is rare. It is estimated that the transmission of hepatitis C is 1 to 1,149,000, and human immunodeficiency virus is 1 to 1,467,000. Protozoan infection and prion disease are also transmissible through infusion but are an even lower risk. Hemostatic abnormalities, specifically coagulopathies and thrombocytopenia, may be transiently related to dilution from administration of large volumes of crystalloids, colloids, or banked blood, but they are more likely caused by the extent of injury and the development of disseminated intravascular coagulopathy, abbreviated as DIC. Banked whole blood is usually reserved for massive transfusions and contains sufficient coagulation factors, including labile factors 5 and 8, to maintain hemostasis during the lifespan of the unit. However, it does not contain platelets because they do not survive the temperatures required for red blood cell storage. Immunosuppression has also been associated with blood transfusions as evidenced by enhanced graft survival in renal transplant recipients, tumor recurrence in patients with colorectal carcinoma, and postoperative infections. Transfusion-related immunosuppression is multifactorial, but it is most likely caused by the infusion of donor white blood cells, which creates a competition between the donor and the recipient leukocytes. Transfusion-related immunomodulation can be limited by leukoreducing packed red blood cells prior to transfusion. The majority of blood in the United States is leukoreduced, but it is not a universal practice primarily because of cost. Patients who are immunosuppressed, undergoing cardiac surgery, or receiving chronic transfusions should receive leukoreduced blood. This mechanism is not, however, the only cause because immunosuppression is associated with autologous blood transfusions as well as the infusion of plasma alone. Because of the limited supply and potential adverse effects associated with blood, research is ongoing to develop blood substitutes. The ideal agent would have a longer shelf life, a reduced risk of disease transmission, and less risk of transfusion reactions. The agents in various stages of clinical research include the modified hemoglobins and the perfluorocarbons. Problems have occurred with some of the products thus far, such as short half-life, vasoconstriction, GI disturbances, and flu-like symptoms. The exact role the blood substitutes would play in transfusions is unclear. No agents are approved, but research is continuing. The next question reads, PTT is a 58-year-old man who arrives to the emergency department via ambulance after a motor vehicle accident. He has remained conscious during the event, but his mental status fluctuates between somnolent and agitated with a Glasgow Coma scale of 10, that is moderate injury. Chest CT reveals a type 2 proximal descending thoracic aortic injury. PTT is taken for an emergent surgical repair of his aorta. He has been admitted to the ICU after surgery and is intubated and receiving 60% oxygen. His ABGs are adequate, and he is receiving 150 ml per hour of lactated Ringer's solution IV. His initial postoperative and 2-hour postoperative hemodynamic profiles are as follows. BP, systolic 86, diastolic 44 and a mean arterial pressure of 58 mm of mercury. Initial parameters were 100 systolic 52 diastolic and a mean arterial pressure of 68 mm of mercury. A heart rate of 96 beats per minute. The initial value was 88 beats per minute. A cardiac output of 3.2 liters per minute. The initial value was 4.8 liters per minute. Cardiac index of 1.9 liters per minute per meter squared. The initial value was 3.3 liters per minute per meter squared. A CVP of 6 mm of mercury. The initial value was 12 mm of mercury. PA pressure, systolic 18, diastolic 8 mm of mercury. The initial values were 24 and 14 mm of mercury respectively. Pulmonary capillary wedge pressure of 13 mm of mercury. The initial value was 18 mm of mercury. SVR of 1080 dyne SCM to the power of -5. The initial value was 1560 dyne S to the power of -5. Urine output of 0.4 ml per kilogram per hour. The initial value was 1.2 ml per kilogram per hour. A temperature of 37.4 degrees Celsius. Initially it was 34.8 degrees Celsius. A hematocrit of 32%. Initially it was 31%. From the hemodynamic profile, determine whether PTT is hypovolemic or experiencing pump failure after his surgery. Most of PTT's hemodynamic changes are consistent with hypovolemia. These include a drop in BP, CVP, PA pressure, pulmonary capillary wedge pressure, cardiac output, and urine output. The decrease in CVP and pulmonary capillary wedge pressure suggests that preload is reduced, resulting in a lower cardiac output. The pulse pressure is narrowed, suggesting either blood flow or ventricular contractility has decreased. Decreases in pulse pressure correlate with decreases in SV or left ventricular stroke work index, abbreviated as LVSWI. PTT's heart rate increased slightly, but it is unclear whether he was taking any medications, such as a beta blocker, before his injury. As body temperature rises postoperatively, vasodilation decreases SVR and increases the intravascular space. If intravascular volume is inadequate and increased sympathetic tone cannot generate a sufficient cardiac output, mean BP falls. The decline in urine output reflects a compensatory drop in renal perfusion. The most likely explanation for the hemodynamic change in PTT is hypovolemia. The pulmonary capillary wedge pressure would be higher if PTT was in cardiogenic shock, although he also should be evaluated for the occurrence of a perioperative cardiac event, e.g. a myocardial infarction. His ABG should be checked to assess oxygen requirements. The next question reads, what are the most likely causes of hypovolemia in PTT? Common causes of hypovolemia in surgical patients are postoperative bleeding, third spacing, and temperature-related vasodilation. Postoperative bleeding can produce hypovolemia, however, PTT's initial and 2-hour postoperative hematocrit of 31% and 32%, respectively, do not support bleeding as a cause. After major vascular or bowel surgery and in cases of burns or peritonitis, patients have an internal redistribution of fluids, called third spacing, which can result in intravascular volume depletion. It is not unusual for patients to third space significant amounts of intravascular volume. The interstitial space and bowel walls can sequester large amounts of fluid, and this can produce a state of relative hypovolemia as is occurring with PTT. This is likely in the first 12 to 24 hours after the surgical procedure. PTT is receiving 150 ml per hour of lactated Ringer's solution, but this is apparently not sufficient to maintain his intravascular volume. Mild hypothermia is common during operative procedures. Vasodilation occurs as patients warm postoperatively, expanding the intravascular space. If the amounts of IV fluids administered are insufficient to compensate for the increased venous capacitance, BP and cardiac output will decline during the rewarming phase, which can range from 1 to 6 hours. PTT has rewarmed from 34.8 degrees Celsius to 37.4 degrees Celsius in 2 hours, which is not unusual after a major operative procedure. His temperature could conceivably rise to as high as 38 degrees Celsius to 38.5 degrees Celsius during the first 12 to 24 hours after surgery. Other considerations include inadequate fluid administration during the operative procedure and the effects of drugs given in the operating room or in the immediate postoperative period, e.g., opioids, sedatives, inhaled anesthetics, that cause systemic vasodilation. The next question reads, how will volume replacement improve PTT's cardiac output and perfusion pressure? The Frank-Starling mechanism indicates that the volume of blood returned to the heart is the main determinant of volume pumped by the heart. Therefore, as venous return is increased, the cardiac output also will increase within physiologic limits until the optimal preload is achieved, at which point further volume has minimal effect on stroke volume. The pulmonary capillary wedge pressure, the best indicator of left ventricle preload, and the CVP, a marker of right ventricle preload and overall estimate of volume status, are low because of declining venous return in PTT. A ventricular function curve can be constructed by plotting a measure of cardiac pumping, cardiac output, stroke volume, or left ventricular stroke work index against a measure of preload. 2 hours after surgery, PTT's CVP has fallen from 12 to 6 mm of mercury and his cardiac output has fallen from 4.8 to 3.2 liters per minute. Therefore, additional volume replacement is warranted. The next question reads, PTT is given a 500 ml bolus of normal saline solution in 10 minutes, and this results in the following hemodynamic profile. BP 96 systolic, 54 diastolic, and an MAP of 68 mm of mercury. A heart rate of 88 beats per minute. Cardiac output of 3.9 liters per minute. Cardiac index of 2.4 liters per minute per meter squared. CVP of 10 mm of mercury. Pulmonary capillary wedge pressure of 15 mm of mercury. Assess PTT's response to the fluid challenge. According to the Frank-Starling curve, a small change in preload in response to a volume challenge with a minimal change in cardiac output represents a ventricle on the flat portion of the ventricular function curve. Additional fluid therapy given to these patients can increase their risk for pulmonary edema without improving cardiac output. In contrast, a large change in preload in response to a fluid challenge with a significant increase in cardiac output represents a ventricle on the steep portion of the curve. In PTT, the pulmonary capillary wedge pressure indicates he does not have pulmonary edema, and the change in CVP from 6 to 10 mm of mercury along with the increase in cardiac output show that he is still responsive to fluid. Thus, it is reasonable to administer more fluid to enhance cardiac output and renal perfusion. The next question reads, 1 hour after the 500 ml normal saline bolus, PTT's hemodynamic profile returns to his postoperative state. ABGs are acceptable, and lactated Ringer's solution is infusing at 200 ml per hour. PTT is continuing to third space intravascular volume. Based on this information, develop a strategy for additional fluid challenges in PTT. Acceptable strategies for administering additional fluid challenges to hypovolemic patients are based on the direction and degree of change in the various hemodynamic parameters in response to a fluid load rather than to their absolute values. CVP has a poor correlation with right ventricular end diastolic volume because it can be affected by changes in intrathoracic pressure, venous tone, and ventricular compliance, distensibility of the relaxed ventricle or stiffness of the myocardial wall. Pulmonary capillary wedge pressure and pulse pressure variation are more predictable markers of fluid status. Left ventricular stroke volume, and thus pulse pressure, is inversely related to intrathoracic pressures during respiration. Stroke volume is maximally affected at lower filling pressures when the ventricles are operating on the steepest portion of the Frank-Starling curve. A stroke volume that varies at least 12% during a respiratory cycle, between end inspiration and expiration, is highly predictive of a positive response to fluid challenge. Some practitioners argue that CVP is still an acceptable gauge of fluid responsiveness when used in conjunction with other parameters, including cardiac output, BP, urine output, and tissue perfusion. Using CVP as a guide, an increase in the CVP of 5 mm of mercury after a 250 to 500 ml fluid challenge in 10 minutes implies the left ventricle is still functioning on the steep portion of the volume pressure curve. If the CVP rises abruptly as fluid is given, with a small change in cardiac output, the flat portion of the ventricular function curve has been reached and the IV infusion rate should be slowed. If signs and symptoms of inadequate tissue perfusion worsen or fail to improve, and if the CVP remains greater than 10 to 14 mm of mercury, fluid challenges should be stopped and inotropic therapy initiated. Most critically ill patients require a cardiac index above 2.5 liters per minute per meter squared and a pulmonary capillary wedge pressure of 12 to 18 mm of mercury, or a CVP of 8 to 14 mm of mercury to maintain an acceptable MAP of 65 to 75 mm of mercury. A downward trend in the lactate and base deficit and a change in hemodynamic parameters as well as vital signs and urine output should serve as indicators for whether additional fluid is required. The next question reads, PTT has received a total of 3.5 liters of normal saline boluses during the past 6 hours and remains hemodynamically unchanged. His urine output has averaged 0.3 milliliters per kilogram per hour for the past 4 hours, indicating volume replacement is inadequate. Given his age and the lack of response to initial crystalloid administration, the decision is made to infuse a colloid solution. How do the colloids compare as a volume expander for PTT, and which agent should be used? Albumin, the predominant protein in the plasma, accounts for approximately 80% of the colloid oncotic pressure, the force that maintains fluid in the intravascular space. Human serum albumin is the colloidal agent against which all others are compared for volume-expanding properties. It is commercially prepared from pooled donor plasma that is heat-treated to eliminate the potential for disease transmission. Albumin 5% solution increases plasma volume by approximately 80% to 100% of the volume infused, with an initial duration of action of 16 hours. At steady state, 3 to 5 days, approximately 40% of albumin remains in the intravascular compartment while the rest is in the interstitial compartment. Side effects involve transient clotting abnormalities and anaphylactic reactions 0.5%, both of which are rare. The anaphylactoid reaction is caused by the pasteurization process, causing albumin to polymerize, which produces an antigenic macromolecule. Albumin solutions also contain citrate, which can lower serum calcium concentrations and theoretically lead to decreased left ventricular function. The effects on coagulation and serum calcium are possibly related to the volume of fluid infused rather than albumin administration. Albumin is available as a 5% solution that is iso-oncotic with the plasma and as a 25% solution that is hyperoncotic. The 5% solution is generally preferred for routine volume expansion, whereas the 25% solution is most useful in correcting hypoproteinemia or intravascular hypovolemia in patients with excess interstitial water. Albumin is subject to availability, as approximately 1 liter of pooled donor plasma is required to produce 20 to 25 grams of albumin. Hydroxyethyl starch, abbreviated as HES, is a synthetic colloid made from amylopectin, which closely resembles human serum albumin but is less expensive. Available as a 6% solution, hydroxyethyl starch expands the plasma volume by an amount greater than the volume infused because the high oncotic pressure draws water from the interstitial spaces. Hydroxyethyl starch solutions have varying locations and degrees of substitutions on the glucose molecules, which slow enzymatic degradation and confer greater hydrolysis resistance. Hydroxyethyl starch solutions have complex pharmacokinetics because of their wide range of molecular weights, with an average molecular weight of 69,000 Daltons and a range of 1,000 to 3 million Daltons. Numerous clinical studies have compared albumin and hetastarch for fluid resuscitation in patients with and without shock. However, most of these trials were underpowered and there were no significant differences in mortality. Although hydroxyethyl starch has comparable efficacy to albumin, controversy exists regarding the use of hydroxyethyl starch owing to adverse effects seen with its use. These adverse effects include severe pruritus, coagulopathy, and renal dysfunction and appear to be class-related effects because the newer lower molecular weight and substitution products are similar. Dose-related reductions in platelet count and transient increases in PT and PTT have been reported with moderate infusions of hydroxyethyl starch up to 1,500 ml per day, and coagulopathies persist for up to 7 days with larger volumes. Hydroxyethyl starch causes factor VIII and von Willebrand factor levels to be lowered beyond that, which can be attributed to hemodilution and also increases fibrinolysis. This places patients with von Willebrand disease at greater risk of bleeding. In critically ill patients, particularly those with sepsis, hydroxyethyl starch is also associated with a dose-related increased risk of acute kidney injury and greater probability of needing renal replacement therapy. Hydroxyethyl starch now includes warnings of excessive bleeding when used in patients undergoing cardiopulmonary bypass, as well as a boxed warning that states these products are contraindicated in critically ill patients. Experts argue that hydroxyethyl starch should not be used because of the potential adverse effects and that other alternatives are available. Dextrins are colloidal solutions that are synthesized by bacteria from sucrose and are available in 40,000 and 70,000 Daltons average molecular weight solutions. These products lack adequately powered randomized trials to adequately examine their efficacy or safety. Like hydroxyethyl starch, dextrins can cause renal dysfunction, bleeding, and anaphylactic reactions. Dextrins can cause acute kidney injury, possibly because of accumulation of dextrin molecules within the renal tubules. They increase bleeding by causing dose-related decreased platelet adhesion, increased fibrinolysis, and decreased levels of factor VIII. Dextrin solutions are associated with the highest incidence of anaphylactic reactions among all of the colloids. Because of the lack of superior clinically important outcomes and less favorable safety profiles for hydroxyethyl starch and dextrins compared to albumin, it is decided to use albumin for further volume expansion in PTT. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 319.